Hello, and welcome to the Secours Richmond Community Education Series on Neuroscience. I'm Pat Lane, the Administrative Director for Secours Richmond Neurosciences, and tonight we have a special guest, Dr. Asghar, and he is the Medical Director for St. Francis and the Stroke Program there. He has his Clinical Neurophysiology Fellowship from the Medical College of Georgia, and he also did his neurology residency at the University of South Alabama. So we were just talking about how he's very proud of Alabama this year. I know there are a lot of Alabama fans out there. He also got his medical degree from the University of South Alabama as well. And this is truly East Alabama, to the University of Birmingham as well. So you are truly a Bama fan. So I think the first thing I really like to do, my guests, because you never know who's listening, and I always want to talk about healthcare. We're going to talk about neuro, but what made you go into healthcare? I think people want to know. And
personally, I went into healthcare. I had some family members in healthcare, and then I think we all have different things that shape our lives. I had a nephew who was very sick. It kind of led me into getting into medicine. So that's kind of the pathway I took.
Okay. And then a lot of people want to know, like, how many years did it take to go to medical school? And then you have to do, when I said the fellowship, how many years is that? And then you specialize, and then you got another specialty.
Yeah,
so
it's a long path. It took us, let me see, so medical school is 4 years, and neurology residency is 4 years, and then whatever you do beyond that is an extra few years. I did a couple extra years of training after residency, so an extra 2 years after residency, which is, so you kind of forget about it after a while. So keep doing your thing.
That's right. So it's about 10 years. People need to know that that's a foundation of 10 years. But I would say in healthcare, you're learning every day. I mean, things are so changing, which is one of the reasons why I really enjoy being in healthcare.
Very true.
You learn different things. And I'll say neuroscience in particular has a lot of new things coming up. The way that we practiced years ago is very different than today. And actually, the brain and neuroscience is in the forefront.
Yeah. Well, I mean, I think, you look out there and most of what you hear about these days is, people have understood a lot about the heart and a lot about the lungs and the liver and the kidney, and I think neuroscience is kind of that last frontier, and that's where we're kind of headed, in the future. Hopefully we can find cures for more neurologic diseases and improve quality of life, which is kind of the name of the game.
Yeah, it's pretty exciting with the neuroscience piece. Actually, I was watching I think it was the NFL football game this weekend, and they had the Dr. Pepper throw. And one of the girls who won, she actually won $100,000 throwing a football. And they said, well, you have to use it for your school and college. And they said, what do you want to do? And she said, I'm going to be in neuroscience.
Yeah.
So I was like, before you didn't really have a degree in neuroscience. Now they're like schools featuring just neuroscience and medical school, but neuroscience is a truly degree. Is really nice to see.
Yeah. So I think there's a lot of exploration out there and a lot of research opportunities, and I think, like I said, that area is just going to continue to grow, and it's unending, basically.
So I do know that one of your specialty is in pain. So we wanted to talk a little bit about that and really define it, because it's not pain, it's pain, it's pain. And I think that's where a lot of people get confused about how to be treated. And so, it might be nice just to give the audience a general definition of pain and how you see it and define it and who you treat.
Yeah, sure. So when, the technical definition of pain is pretty general, so it's defined commonly as unpleasant sensory or emotional experience, and that's obviously very vague. But using common sense, people know what pain is. They know what that hurt feeling is, And the reason they see, the reason you go to your doctor is, your body is telling you something is not right. So, and that's really the most simple definition of pain. There's varying kinds of pain, but we can get into that a little later. But we'll just kind of explore that topic a little and kind of give you an understanding of what some options are when you start experiencing pain.
Okay, so, I may be in a little pain, and I'll take something. Let's just start with that. What are the things that are out there over the counter if
Sure.
somebody's having some types of things that you see?
Well, the common causes of pain are, a brief injury or arthritis, right? Let's take those. Certainly after you've had some brief injury, you hit yourself, maybe playing sports or doing whatever it was you're doing, your body's reaction to that is inflammation because it's a marker that, hey, listen, this area has been damaged. Let's rush some different chemicals in the body over there to try to settle this down, right? And so, you would normally go to your local pharmacy, pick up something over the counter, most commonly an anti-inflammatory medicine, things like Aleve, naproxen, ibuprofen, and those would be pretty appropriate to take for kind of an acute episode of pain. Tylenol can be very helpful, works a little differently than ibuprofen and Aleve, but both basically generally helpful. And the goal of those medicines is to reduce the inflammation and thereby reduce the pain, and that should be basically a self-limited episode of pain.
Mm-hmm. And I think you said a key word that I know we use a lot, and that's acute. So that means a short time. So you shouldn't be taking that every day like you take a vitamin. So.
Right, yeah. Any medicine can be helpful, but at the same time, any medicine can be hurtful. So, all things in moderation. And so, certainly if you're taking a pain medicine, if it's over the counter, take it based on the directions on the bottle. If your pain is lasting longer than a few days or a week, maybe that's a signal that, hey, look, this is not really something too minor. Maybe I should see my primary doctor, get them to check it out. And your primary would see you, determine whether you needed to stay on that medicine or give you some other guidance. But, the downsides of taking any type of chronic medicine for pain are that it can cause you to have particularly, stomach ulcers, your body can get tolerant to that medicine and then it not be effective. Basically those are the main reasons. So you want to take the medicine when you need it, and you want to stop taking it as soon as you don't need it anymore.
Mm-hmm. So I'm in pain. I've gone to my primary doc, and he says, this pain isn't getting any better.
Right.
And now I may say, you might need to go see a neurologist.
Sure.
And that's where you certainly would come in and talk to them and do an assessment. What would be some of the kinds of things that you would be doing?
So, certainly reasonable for your primary doctor to send you on to someone else when the pain is not getting better and what they've done, hasn't been able to control it. So normally a patient will be sent to a neurologist for particular kinds of pain, right? So the main reasons they would be sent to a neurologist are, for example, if they had a pinched nerve, right? They said, or they felt like they had a pinched nerve. People call it sciatica when the pain is shooting down your leg. Mm-hmm. Similar, you can have that same pain in the arms if there's a pinched nerve in the neck. And and the neurologist's role is to kind of see you, take your history, examine you, and kind of determine where they think your pain is coming from. So, if we think your pain is coming from a pinched nerve in your leg, we may recommend conservative care, maybe some anti-inflammatories, muscle relaxers, a course of physical therapy. If that doesn't work out, we may move on to doing a nerve test to sort out, okay, is this, a pinched nerve in the leg, or if it's in the arm, is this carpal tunnel, is this pinched nerve in the neck, those kinds of things. And that's kind of what most neurologists do in terms of the diagnostic portion. Separately, we would try to help you treating pain, and the majority of neurologists will use medicines like Lyrica, Cymbalta, gabapentin, Neurontin, and those can be helpful. But the majority of neurologists will probably not be prescribing any narcotics because they're mostly not comfortable with that.
And I think that's a good point. I mean, they make sure that these medications all have side effects and can certainly alter you as well. And I was just going to say one thing that I think is important is making sure all your physicians know your medications, because that is some chemistry, and then when you're taking certain medications, they can mix and do some other things as well.
No, that's very important. A lot of times we'll see patients who are on multiple medicines, and you're considering prescribing one medicine, and then you see, wait, well, this other one may interact. So, your physician, your doctors are always trying to make sure there's less interactions between your medicines. So it's always good for everyone to be on the same level in terms of what you're taking.
And that includes even, like, I know people have holistic medicines, or they may take some different, not only just tablets or some teas or certain foods. So very important for you to share that health history with your doctor so that they can make sure you're going down the right treatment path. And I know you also do work at St. Francis with a pain clinic, and you do some things in the OR.
So so my training took a little different path than most other neurologists, or the majority of neurologists. I decided somewhere towards the end of my residency to focus on pain management issues, and mostly because I had some exposure in residency to seeing how a pain clinic worked. And I think this will be particularly important to help the audience understand the different kinds of pain management. So pain is coming from somewhere, right? So the common causes of pain would be, let's say, back pain or neck pain, and there's various sources, meaning like degenerative disc or arthritis of the back. And so I had some additional training where I learned different injection techniques to go to the source of the pain and try to treat it there, so you obviously would have less pain, and that it would help the patients avoid taking narcotics for their pain. So that's one of my main philosophies is to approach it with an injection at the source of the pain and avoid putting somebody on narcotics or prescribing any long-term narcotics. So I feel pretty strongly about keeping patients away from chronic narcotic pain medicines.
Let me ask you something about history. If somebody, and you said arthritis is a good one, if you have a family history or genetics, does that tend to run in families? Or?
In terms of arthritis, people ask me that a lot, and I tell them, if there's a family history of rheumatoid arthritis, that certainly tends to run in families. And rheumatoid arthritis is that arthritis where people have the disfigured joints on their hands, and it's very obvious. Now, the other arthritis is called osteoarthritis, and that's really kind of run-of-the-mill, and there's really no family history or not really inherited, okay? And then to kind of follow that through, patients will say, well, I have a family history of degenerative discs, is there some link with my family? And I say, well, the truth of the matter is, degenerative disc or degenerative spine is a normal aging process. Sometimes it happens earlier in life to others because of maybe their work history. Maybe they were, if you laid bricks your whole life, or you worked heavy manual labor, well, you're really putting your back through a lot, and it's going to wear and tear earlier than if you had a desk job and you were 50. So I think more of it actually has to do with kind of the types of work you've done, and less so inherited family things.
So we talked about holistic a little bit. Is there anything that you usually tell your patients about diet or exercise and pain, or do you guys talk about that at all?
Well, I don't think there's a lot of data or research to suggest different diets as a way to modify pain, but certainly eating a healthy diet, eating a lot of fruits and vegetables is generally good for you. And another way to look at this is that, well, you know, a diet heavy of fruits and vegetables and low in fats, basically that those diets suppress inflammation, generally speaking. And if you think about pain as being an inflammatory response, well, there's some potential that that would be a helpful thing, although we can't really say that definitively. But, you know, I mean, it would be a good health move, and the healthier you feel, the healthier you are, the less pain you feel. So.
And I think that's true. That's where the research comes in, I think, and looking at neuroscience and down the line, and maybe what does that do for your brain and making your body feel good. So he talked also about Dr. Asghar being also the medical director of stroke at St. Francis, which is out on Midlothian, and we're very pleased about that as well, because that program actually was one of the first programs who had what we call target stroke, meaning that they met their door to needle time 60 minutes or less, and they've been doing that for the 50% of the time, and they were like the first ones to do that. So very proud of that over there. And stroke is a major disability.
Yeah.
So I do want to talk about that a little bit, especially the holidays are coming up. People get really stressed out, and there's some things that I think we could talk about with their risk factors.
Yeah, sure. So, certainly, stroke is one of the most disabling conditions and one of the top causes of death in our country. And we'll kind of go through what risk factors for stroke are, what signs and symptoms are, and how to approach that. So, risk factors for stroke would be, elevated cholesterol, chronic high blood pressure, diabetes, smoking, major risk factor, and age is a risk factor. So certainly those are the major risk factors, and whereas you can't modify age unless, and if you can, please call in and let us know how, because we can
certainly
make some
use
money.
that, absolutely.
But the goal is really to work as close as you can with your regular doctor. See them on an annual basis. See them twice a year. Get your blood pressure, your diabetes, cholesterol, all under control, so you don't get to the point where you've had a stroke and you don't need to be in the hospital. That's the best situation. But the signs of stroke would be numbness on one side of the body, weakness on one side of the body, difficulty speaking, slurred speech, your face looks droopy, you're unsteady walking. And so if you ever experience that, take it serious, if that doesn't get better, in 10, 15 minutes, pick up that phone and call 911, because the sooner you can be evaluated by the EMS and taken to the hospital, the sooner the ER doctor and the neurologist can decide whether you're actually having a stroke. And if you are, you can be treated with a clot buster that would hopefully resolve the symptoms of stroke and prevent you from getting worse. So, it's very, very important. Take it serious.
So I know one of the things I think is important too, and I talk about this time of the year, everybody gets really stressed at Thanksgiving and they eat a lot, and the other thing is hypertension and blood pressure.
Oh, yeah.
So another great debate has always been, who should manage the blood pressure? Should it be a neurologist, cardiologist? So how do you play into that in your numbers?
I would say that, I think the most practical way is really for the patients to work with their primary doctor, or if their blood pressure is very severe, their cardiologist. Neurologists are definitely willing to help, but because there's so few of us relative to others, I don't really think it's practical to suggest your neurologist manage your blood pressure. But what patients can do is take that responsibility and measure it at home and stay after it and track it. And so when you show up to your primary doctor's office, you can say, hey, Dr. So-and-so, I watch my blood pressure a couple of days a week, I wrote it down, this is what it looks like. So when he sees you, he or she, they can look at those numbers and modify your medicines to kind of get things under better control.
And that's one thing I always say, strong family history too. If you have family history of somebody has hypertension, maybe high cholesterol, diabetes, that's where that conversation comes in earlier with telling your health practitioner, this is my history, this is where I'm coming from, am I at risk of that? And the other thing is ask questions. I think people don't do that as well with their physicians or their practitioners. They don't ask. Let somebody take your blood pressure and they'll say, oh, it's good, and you don't talk about it and say what those are, and I think that's important.
Yeah, to give you the best health you can possibly have, I mean, you have to, we all have to take responsibility, myself included. We have to show up to the doctor's office whenever they tell us, a couple times a year. We have to play our role so that they can help us, right? So, and then, it's our responsibility also to ask questions, hey, parents had a heart attack at a young age, maybe I should get checked out for that, do I need to have this or that test? Certainly preventive care is a big deal, and and that can only help you in the future.
Mm-hmm. So if somebody, we talked about the signs and symptoms of stroke, we talked about the risk factors. Let's say if somebody were to have a stroke, I kind of say go to a primary stroke care center. You talked about getting the clot buster if they're there within 0 to 3 hours, but it's a journey. If you have a stroke, the neurologist will certainly follow them after that, and you'll see them, and you want to tell them a little bit about what kind of tests they'll get there and their journey after that.
So, certainly if you have stroke symptoms, and you should go to the ER, and if you have stroke symptoms, you'll most likely be admitted to the hospital, and there will be a series of tests done. Certainly the common test would be an ultrasound of your heart to be sure that there's not a clot in your heart where the stroke came from. It didn't shoot up from the heart to the brain. The other test would be a scan of the arteries in the neck to see if there's any narrowing in the neck and whether that was a cause of stroke. Otherwise, we look at, and if we can, if you don't have a reason that we can't do this, we would do an MRI of your brain and look at the arteries within the brain to look for aneurysm or to confirm or diagnose the stroke. And the reasons you couldn't have an MRI would be something like a pacemaker or other kind of implanted electrical device. But I will say that the newer generations of pacemakers are becoming MRI compatible, and they usually give you a card that tells you, if you can have an MRI or not.
I've seen people who get really confused and may have had, I should say confused, a TIA or a transient ischemic attack, and so they won't do anything because it's very fearful. And I said, that's just the opposite. You need to let somebody know. Yeah. And a lot of people will just go to sleep or say, oh, well, I just felt funny, but it went away. Yeah. You have any advice for that?
Yeah, I would say that if we all have a little numbness and tingling every now and then, and certainly if it went away within a few minutes and it didn't recur again, maybe that's nothing you need to do anything about. But if you have some kind of numbness or weakness that persists for more than 10 minutes and it's not normal for you, take that thing serious, because the worst situation is where we feel like, oh, this is a little numbness or a little weakness, I'm just going to take a nap. And you take a nap, and you wake up a few hours later, and that numbness is still there, and you're not moving your arm or your leg. Unfortunately, by that time, doctor can't do anything about that. The time frame to give the clot busting medicine has already passed, and we can't really change it at that point. So certainly, if you show up early enough, within the time window is up to 3 hours, but certainly you don't want to show up at 3 hours. You want to show up early. And we can get the history and examine you, and if you're a candidate for that clot buster, we would give that to you, and hopefully that would dissolve the clot, and you would not have the residual weakness that you had. So use your discretion, but if anything is lasting longer than 10 minutes, 15 minutes, then you need to really you need to call 911 and probably go to the ER.
Thank you. So we're talking about general neurology tonight. If you want to call us, you can call us at 804-915-5202, and we'll take calls until about 6:45. So I now want to go talk about something else that I think a lot of folks want to know about, come to neurologists about, and that's dementia and Alzheimer's. And they're different. And people use them interchangeably, and I don't think they really are. And I think neurologists are the only ones that kind of help us with that.
Yeah, well, so dementia is the broad term for kind of progressive cognitive or memory function impairment as you get older, and certainly it doesn't happen to everybody, but it's more common if you have a family history of it. Now there's multiple categories of dementia, and it can become very academic, but the most common form of dementia is Alzheimer's. So 7 times or 8 times out of 10 when somebody has dementia, they develop, it's categorized as Alzheimer's, which is basically the most common kind. There's other subcategories of dementia, like one called frontotemporal dementia, where they have a little different presentation. Go ahead.
Hi, caller.
Hello, thank you for all the good information. I got a question. You were talking about pain, and I was just wondering, do meds kind of mask the injury? In other words, if you're taking pain medication for pain, and let's say your knee, for example, are you injuring your knee by still walking on it and you don't feel the pain? The injury is still there.
Yeah, well, I mean, that's
hurting yourself more.
Thanks.
Okay, yeah, no, that's a reasonable question. It's a good question. Yeah, so like if the pain is acute, then using the anti-inflammatory or the pain medicine, for some short period of time, maybe a couple of weeks, 2 weeks, 3 weeks, is probably reasonable. Now, acute pain will go away. I mean, that's the nature of things, It's an injury, it should go away, but if the pain is persisting, then you kind of have to look into that a little further, get your doctor to look at it. If you gave the example of a knee injury, well, you may have torn a rotator, you may have torn a meniscus, and maybe you need an x-ray of your knee or an MRI of your knee and see an orthopedic. Because, yeah, certainly if the injury is bad enough and you cover it up with pain medicine over a long period of time, well, maybe you are progressing on that injury. So, yeah, in the short term, use the pain medicine. If it's persistent, follow back up with your primary and say, hey, look, this is not getting better. Maybe we need to kind of look into this a little more and kind of get that guidance at that point.
It's a good question. What we didn't talk about, well, I have it on my list while we're talking about pain, is probably migraines.
Yeah.
That's a big one that I know a lot of people go to neurologists for as well. Migraine, headaches, and a headache, when you know it's a headache and when you know it's migraine. And
yeah. Okay, so we'll talk, headaches. So, headaches are common. A lot of people will get sinus headache every now and then. Sinus headache is typically kind of a frontal headache over the eyes or in the cheeks, right? And that's where you feel that kind of pressure. And that's kind of the location of a typical sinus headache, more like a pressure headache in the front of the head. So, I think everybody's pretty aware of that. So, you'll normally see your primary, take an decongestant, kind of let the sinus thing work itself out. A lot of times we'll see patients who say, well, I thought I had a sinus headache, I took all this sinus medicine, but it still persists, and then we'll start exploring that a little further. So what I'm going to do now is separate migraine from non-migraine, right? So we'll talk about tension headache. So tension headache is going to be kind of a diffuse, dull, pressure, tightness headache. And people sometimes say it feels like a vice grip or pressure like that. And it's kind of a constant thing. Tension headache is mostly associated with underlying stress, anxiety, depression, something going on in your life, you're stressed out, I got this headache. That particular headache is mostly described as mild or moderate, not described with throbbing, shooting, pulsating, vomiting, nausea. No, none of those. But mostly kind of a mild chronic pressure headache. That would be a tension headache. Separately, you get into migraine, which people describe as more severe pounding, shooting, stabbing, pressure, And they also kind of will say something like, well, we ask, is there any vomiting, any nausea, any light or sound sensitivity? And it can be all of those or none of those. Usually it's going to be one of them as kind of other ways to describe the headache. Or as associated symptoms. And so we treat migraine a little differently. We would try to put you on a headache prevention medicine and then to reduce the number of headaches, and then give you a medicine to use every now and then when you had a severe headache. Okay?
So yeah, and that was good. And then I'm going to ask about going back to stroke and headaches, because this is where I think it gets confusing, particularly for those who have migraines. When you hear somebody said, I have the worst headache of my life, and that could possibly be a hemorrhagic stroke.
Correct.
So I was thinking about that when you said it.
That's a good segue. So one thing to always remember, people can have migraines, they can have chronic headaches, that's fine. If you ever experience the worst headache you ever had, I wouldn't chalk it up to being a migraine. Okay? I would say if you get to some point where you say, this is the worst thing I've ever had, you need to go to the ER. And the reason is those particular headaches can be related to bleeding in the brain or an aneurysm. And the only way to know that is to be in an ER where they scan your head and look for that possibility, because obviously that would be treated completely different than a routine migraine. Mm-hmm. So if you ever have the worst headache of your life, make a straight line to the ER.
Mm-hmm. And I think, again, that's the key. Know your body is what we're saying. Know your primary care physician, and know that they will send you to a specialist if you really need that to happen, so that you can get back to your baseline, or we can be able to treat the symptoms of whatever it is you need, and you need to be really clear on what those symptoms are. So we were talking about Alzheimer's and dementia, because I know people like to hear more about that.
So I'll continue on with that. So, I think we left off where Alzheimer's was the major category of dementia, and then there were a few other smaller subcategories. And generally speaking, in Alzheimer's, people, they start to lose. I'll give you some examples. I always ask patients, okay, so, what kind of memory problems are you having? People will say, well, I can't remember things as good as I used to. I'm forgetful. I don't know where my medicines are. And sometimes they progress to the point where they're not able to really manage their own finances well, making mistakes, missing bills, or, as they can get lost driving because they don't recognize their environment anymore. And so we'll try to help manage those symptoms. And the major thing to know about dementia is, the sooner it's recognized, the sooner we can treat it. And the reason to treat dementia is to slow down the progression of the disease. There's no cure for dementia yet, but hopefully there will be in the future. But what we try to do is get you on the medicines early enough to, if you were going to kind of decline rapidly, we would put you on medicines to slow that decline down and to keep you as independent and as functional as possible for as long as possible, and basically to improve the quality of your life.
Yeah, so again, that's how you know you need to make sure you know what your baseline is, what your function is, and I think this is where family members come in.
Oh, definitely.
And saying, I noticed that you're, not right, or you're pretty forgetful, or because they may not see that. They don't see that. So just being able to recognize that. And again, it's not like how things were years ago. Now we have treatments that may be able to help, again, slow that progression. Same thing with stroke. You don't have to say, if you have a stroke that, I'm done and that I will have this for life. If you go to the hospital early within those 3 hours, you'll be able to get possible treatment depending on what type of stroke you have had. So again, it's very important to do that. I think the one thing we haven't talked about when we looked at neuroscience is there's some other things that neuro is really known for, and that's multiple sclerosis and Parkinson's and movement disorders.
Sure.
Yes, caller?
Yes, I'd like to know if the doctor can explain what is actually going on in your head when you have headaches. I'm going to hang up and listen.
Okay. Yeah, so interesting question. So headaches. So I don't think anybody can... so I'm going to explain it two different ways. I'm going to explain migraine, and then I'm going to explain chronic tension headache, okay? So, so the tension headache is related to stress, anxiety, depression, whatever is going on in your life. And like I said, those people feel kind of a chronic tightness. Some people say like a band squeezing my head. And there's nothing physically going on in your brain for that. And it's actually interesting because it's how, in that setting, it's how your brain perceives the pain that you're going through. So I can't tell you that one part of your brain is hurting or there's something. I can only tell you that's how your brain senses pain in that situation. So tension headache due to stress, okay? Now the migraine is a little different. Studies early on, or I don't know how early on, but within the past 10 or 15 years, there was some idea that migraine was because the vessels in the brain were slightly dilated and they were releasing some neurotransmitters or chemicals, and that is what was actually causing the migraine pain, which is why they invented a category of medicines called triptans, and Imitrex is the most popular of all those. And those medicines in particular make those vessels kind of tighten up or squeeze to reduce that dilation, and that's the idea behind how those medicines help migraine. So those are the two big categories of headache: tension headache and migraine on the other side. And while I can't really explain why you feel the pain you feel for tension headache, there's somewhat of an explanation for the pain during migraine.
With tension headaches, and you're definitely the physician here, but I always think with tension, because you're stressed, you may not be eating right, you're not sleeping right, you're worrying a lot. It's just your body is just tired and achy. It's a lot when you go with that.
Certainly
tension
not
and
any
stress.
one thing, but a tension headache would be a combination of all of those things kind of weighing down on your mind, causing that response of the headache. That's probably as close as I can get to an explanation.
And so what's the treatment for tension would just be? So
treatment for tension headache would be addressing the underlying stressors. All right, I'm sorry, go ahead.
Yes, caller, thank you for calling.
Hello. I'd like to know, why would someone wake up with a headache? Shouldn't they be well rested?
Interesting. Yeah, so
thank you, caller.
Why would you wake up with a headache? A couple reasons. So one of the most common reasons, one of the things that neurologists should always ask, or primaries for that matter, primary docs, if a patient is constantly complaining about, every morning I wake up with a headache, and there's a couple questions that always follow that. The first question is, okay, well, how do you feel during or does the headache get better during the rest of the day, yes or no? And sometimes patients say, yeah, the headache is bad when I wake up in the morning, but after I kind of get going, it kind of goes away, but it's always when I wake up. Well, the second question is, okay, well, do you feel well rested during the day or not? Oh, no, I'm kind of fatigued. Or, okay, well, do you feel very tired during the day? Yes, sometimes I feel very tired. Well, what I'm leading to is you may have sleep apnea, snoring, not resting well, not oxygenating your brain, and those patients commonly have morning headaches. So if you have frequent morning headaches, you need to talk to your primary doctor about symptoms of sleep apnea and kind of explore that issue. And the other reason you could have morning headaches is, unfortunately, some patients take too much headache pain reliever, which leads them into something called medication overuse headache. And the way I explain that is, it's like fuel to the fire. The more headache pain reliever you take, you stay in the cycle of headaches. And you never get out of it because you're always feeding the headaches with pain medicine. And the only true way to get out of it is to stop all those pain relievers cold turkey, give your brain a rest. The headache will get worse, but then it'll start to get better, less frequent. And then, yeah, if you have a headache, you can take a pain reliever every now and then, but not more than 3 days a week to prevent getting rebound headaches.
So you bring up a great point. Now, I've never had a migraine, but those who have migraines say they're horrible. But I know when you first start or go see, the first thing you do is cut off everything. And that's, I mean, I've heard that is really hard. Yeah. But people don't understand that. But you explained it really nicely.
So yeah, a lot of times, not uncommon, we see patients with chronic headaches and we tell them, hey, and we explore, hey, what do you take for headaches? They say, well, do you take a headache pain reliever every day? Yes. I say, okay, well, what do you take? Well, I take Tylenol. Well, how many tablets do you take? Oh, I take 3 tablets. How many times a day? 3 times a day. And you do that every day? Yeah. Oh, what else do you take? I take Aleve, I take Excedrin. So all of that is medication overuse headache. And the first thing you can do for yourself is recognize that, if you're watching, cut that out and let your brain rest. And then the headaches will probably get better even without you seeing somebody. Now, if the headaches aren't getting better, that's when you go see somebody. Yeah, a lot of times patients will hear that. We'll hear a doctor say, you got to cut all that stuff out and go cold turkey. And, we joke, we say 50% of them believe us and see us again in a few months. The other 50% never call us back. So, And
it's a wow. I mean, when you're saying it takes more than a day. So I'm saying you have patience, and I would tell you those who stick with it say, I thought it was the worst time that I was going to have, but after I got through and clear, it is much better now. But you have to have patience with that. You brought up something else though about sleep apnea, which I think is important when we talk about possible risk of stroke as well. So you want to know what's going on with your body. If you're not feeling rested, getting sleep is very important as well. So we want to just make sure we're looking at that too.
Definitely.
So we were talking about maybe movement disorders, Parkinson, people come to neurologists for Parkinson's, movement disorders, multiple sclerosis as well. You have anything you want to share about those too?
Yeah, sure. So the Parkinson's is something that you'll recognize, or you'll have a question. You probably have known somebody with Parkinson's, or somebody's family member had it. So Parkinson's is a movement disorder where people have reduced movement. So they may start walking slower, maybe hunched over a little. A lot of times you'll see that they have a kind of a subtle hand tremor. Mostly when they're just resting, you'll see that hand tremor. And they may talk slower, their writing may become very small. And it's really kind of a constellation of symptoms that, your primary doctor or your neurologist would recognize and kind of put it together and say, well, examine you and say, well, I think these are symptoms of Parkinson's, and there's definitely treatments for that. And the reason people get Parkinson's is that there's a chemical in the brain called dopamine, and your brain isn't producing enough of that, which is causing that slow movement. And essentially, there are many different medicines out there that either increase the activity of the remaining dopamine or add back extra dopamine to kind of get you back to where you need to be. So that certainly certainly takes a lot of work with your primary doctor and in particular your neurologist. So separately, multiple sclerosis is, I think we're all aware of that, and we've known patients or family members or friends with MS. But to summarize, MS is what we call a demyelinating disease, where the covers of the nerve fibers in the brain and in the spinal cord get attacked by the body itself, and it slows down how those nerves transmit signals. So then patients develop all the other symptoms like, they can develop weakness, they can develop spasms, they can develop difficulty walking, they can have different dysfunction with their, not thinking straight, chronic headaches. So MS is a pretty serious condition, and certainly if you have a constellation of multiple symptoms, you're going to share that with your primary doctor. And if your primary is not comfortable, they're going to send you to the neurologist. And, we would have to do some different tests on you, MRIs predominantly, to kind of determine whether there's any evidence of MS. If there is, then you certainly, explain the diagnosis to you and kind of talk to you about the different treatment options.
Now I'm going to ask you something really off the cuff that I just thought about, and I'll talk about Muhammad Ali,
Right.
and what's going on with him, because he has Parkinson's, but he was a boxer where everybody knows, well known, well renowned, and he got hit many times.
Yeah.
Is there any research of that causing Parkinson's or being hit so much, or?
Yeah, I mean, it's certainly, he's one of the most famous cases of kind of post-traumatic Parkinson's. I mean, his situation was that he had so many repeated head injuries, he essentially damaged those parts of the brain and developed Parkinson's as a result. Who knows whether he would have developed it on his own, but it's probably unlikely. So yeah, kind of repeated head injuries are not a frequent cause of Parkinson's, but definitely one of the causes. And certainly other causes of Parkinson's would be, having a stroke or multiple strokes can cause you to have Parkinson's. Ironically, being on certain antipsychotic medicines actually counteract the effect of dopamine, thereby producing Parkinson's symptoms. But your psychiatrist may feel that you have to be on it, whatever those medicines are, to kind of keep your brain stable. But the flip side is that it could cause Parkinson's symptoms, but not always, but it could. So.
We talked about you being a football fan in Alabama. I mean, I think the one thing we will always stress for those who are playing sports is to wear helmets, because concussion syndromes are true and real.
Definitely.
We've seen that neurology people coming to get injury or have had injuries and coming to neurologists to have those follow-up appointments, and now the league is very strict on if you've had it hit your head, then you need to come out and they need to do certain tests on you.
Well, so concussion has evolved over the past 5 years. It's pretty much where it's really had a dramatic change in how we approach that. In the past, I should define concussion. So concussion are the symptoms after a head or spinal cord injury. And the reason you have the symptoms is that if you imagine your brain is floating around in your skull. It's not rigidly attached. So there's fluid that kind of keeps it floating around. And when you are hit or you hit something, your brain kind of rocks back and forth or hits the sides, and that produces the concussion symptoms, which could be, passing out, could be kind of shell-shocked or kind of a dazed, not really kind of with it for a while. People can have, headache or, that would be more delayed symptoms, but, just not recognizing people and confused. That would be the most early symptom. And certainly if you had an injury to your neck, that could shock your spinal cord, and you could lose function from the neck down. And sometimes you'll see that when people are playing football and they got hit bad enough, you'll see that they just kind of lay there, and commonly called a stunner, or a stinger rather. But luckily that recovers most of the time. But you said, like you were saying, there's evolution in that. Now that when people have a concussion, the sports rules are very strict. You got to pull these people out, watch them on the sideline, make them go through a certain number of tests. If they're perfectly clear and nothing is wrong, they may be able to get back in the game. But if that concussion was bad enough to take them out, they're probably going to sit out for another 24, 48 hours just to let their brain rest.
Why do they, or I've heard that they make you not be able to go to sleep? Or I've heard that after you've had a head injury or like a concussion, they try to stay awake.
Yeah, I think what physicians really are concerned about is that we want to be sure that even after your concussion, we want you to be awake. We want to be able to know that that there's nothing making you drowsy or sleepy. So if they keep you up for 5-6 hours, just say, hey, stay awake. We want to make sure that you're not falling asleep or anything like that. I think it's really to just make sure that there's no sign of brain swelling that would cause somebody to be drowsy.
Okay.
So important for somebody to try to keep somebody as alert as we can. In the first few hours of that, make sure everything looks stable before we allow them to kind of, if they decide to take a nap or whatever. So.
Should they always go and get diagnostics done, a CT or MRI, or is that just dependent on how they look? Or
I think that's kind of a hard question to answer. I think, certainly concussion, not everybody with a concussion goes to the hospital, but when should you go to the hospital? Certainly if you had a concussion bad enough to kind of, certainly if you passed out from it, you definitely have to go to the hospital. If it was if you got hit in the head mild and you were a little dazed but then after, some short period of time, you got, things got back together and, you don't have any other issues. Hard to say that you have to go for that. But certainly if you hit your head and you start having headaches or confusion or memory issues, you definitely need to get with your doctor and get checked up for that.
Okay. So we did not talk about if you're having pain and somebody needs to come and see you and wants to come and see you.
Sure, yeah.
How do we do that, or how do they schedule time in the OR?
Yeah, sure. Yeah, so part of my training, as we talked about earlier, was in pain management and mostly procedural pain management. And so the long and the short of it is, arthritic pain or arthritis or degeneration of the spine is extremely common. As we get older, it's probably going to happen. And it's very easy to get an appointment. We'll be happy to share that number. We have 2 offices. One is in Chester on Iron Bridge Road, and that number is 285-6880. The other office is in Midlothian at Watkins Center, and that number is 325-8750. And basically, you would mostly have a referral from your primary doctor. Always like you to have some kind of imaging results before you come and see us so we can go over that with you. And then we talk to you, and then we examine you and talk to you about how your exam correlates to your imaging and what type of physical therapy or injection therapy could be helpful for your back pain, or neck pain or wherever that pain may be coming from. And really my goal is just to try to help people maintain independence, be more functional, reduce pain, and most importantly, I personally don't want to put anybody on long-acting narcotics because I don't believe that's in their interest in the long run. So really want to help you out, improve your life, reduce any kind of narcotic dependence or anything related to pain meds.
And most neurologists feel that way.
Yeah,
most neurologists, and I want to stress that, but you said,
most neurologists are not going to prescribe you narcotics because most neurologists don't feel comfortable doing it, and we don't want to get you hooked on anything that's not going to be good for you later. We definitely don't want to put you on that stuff. So, always happy to see people, try to help people improve their life, quality of life, but, as I say, do no harm.
Mm-hmm. And I think it makes sense. It will alter something, and for us, that's what we're trying to preserve the brain. So I think it just doesn't make sense for us to, most neurologists to do that. So we can manage it, but in very different ways.
Right.
So I think that's good. So we want you to know that if you do need any type of neurology services, that you certainly can come to Bon Secours, and you can go to our website, bonsecours.com, and you can go and look under Neurosciences. You'll see all of our physicians there with all of their specialties, and I think Dr. Asghar did a very nice job tonight talking about all of the things that you can see for neurosciences, which we talked about: Alzheimer's, dementia, pain, migraines, Parkinson's, and we actually do, and definitely stroke and TIA. On our website, we also have a little bit about all of the information that we went over, so the community can learn about that as well, and be happy to talk with you at any time. We also have nurse practitioners on our team as well, and we're always willing to come out in the community and to help to educate. So we certainly thank you for, listening to us on our neuroscience series. One thing that we didn't get into tonight, but we did have 2 series that I do want to stress that you can go to our website and be able to see our link, was epilepsy, which is another thing that definitely you have to see a neurologist for in that. And the other thing, last week we talked about brain tumors and the Cullether Center. And the Cullether Center is the only one actually in the United States that will see anybody that has a brain tumor and will be able to see them for free. Cole, I'm going to try to get you on. You have a question?
No, I just would like to know, when will something like this be shown again?
Well, you know what? Thanks, caller. Well, thanks, caller. We're going to have it actually on our website, and you'll be able to see it at any time, probably after next week when that taping ends. So thank you. I'm glad you found this very interesting. We certainly, again, will have all of our series up, which I went over Alzheimer's. We also went over pain, migraine, headaches, brain tumors, stroke, the risk factors. That will be on our website, bondsecours.com, and you can go under neuroscience specialties and you'll be able to see it all. Thank you very much for being here tonight, and it was very good.
Okay.
Thanks.
All right.
It wasn't.